Next up, we'll take a deeper dive in our panel discussion on how COVID-19 has accelerated adoption of digital health and digital care. Our moderator is Francis Kong, MD, co-founder and curator of Imagine Talks. For over a decade, Francis has balanced between the worlds of healthcare, technology, and collegiate mentorship. His path in healthcare tech strategy evolved from his passion for technology, business, and medicine. Francis served as the lead strategic consultant at one of the largest Catholic healthcare providers in the nation, Christus Health, to guide their innovative ideas of technology and business. I'm going to hand it over to Francis to get the panel started, and he'll have our panelists introduce themselves. So please welcome the panel to the Zoom stage.
Okay, hello.
You're on.
Hi, Laura. Hi, everybody. Laura, should we, do we go into, I'm just gonna go in gallery view so I can see everybody, okay?
Okay.
Fantastic, okay. So, thank you for joining us today, and Laura did a great job of introducing the topic to the panel, and you saw some of the great panelists. I am going to ask the panelists to introduce themselves so they can give you some of their background, and before we dive into the really cool, exciting topic today. So I'm gonna just go based on the order I see on my screen and who I see here. Let's go with you, Dr. Larry Ozeran, and tell us a little bit, within 1 minute, tell everyone a little bit of who you are and what you're excited to share about today.
Glad to be here. My background is as a software developer, a trauma surgeon, a healthcare organizational leader, and a health policy advisor. I provide support to healthcare organizations, government entities, and startups in the areas of strategy, policy, and innovation. And then later today, I'll also be talking about the startup that I'm running where we are aggregating patient health information so that they can be empowered and participate more in their healthcare.
Fantastic. Thank you so much. Nicoleta, would you like to go second?
Absolutely, thank you. I'm Nicoleta Bugnario. I'm the Dean of Health Sciences at University of the Pacific. I'm here on behalf of the future healthcare providers who are excited of using innovation and digital technologies to deliver care to patients. We have 9 health profession programs from physician assistant, nursing, physical therapist, audiologist, social worker, you name it, in our academic portfolio. They spend a lot of time with patients. We have clinics that we had to switch to telehealth due to COVID overnight, very much like we switched our mode of education to online overnight. And personally, I'm a clinician, I'm a physical therapist, a neuroscientist by background in research, and I've worked with different technologies, robotics, sensors. I'm interested on the remote monitoring of the patients, and very excited about this. I think the innovation in technology and healthcare only brings good things for the patients, for Sacramento as a city of innovators, and excited about this panel and great presentation before.
Thank you so much, Nicoleta. Davis, would you like to go next?
Yes, hi everybody. My name is Dr. Davis Liu. I'm a board certified family physician. From 2000 to 2015, I was in primary care at Kaiser Permanente there in Roseville, and then also on the board of directors for 9 years. Since 2015, actually, I at the startup Lemonade Health, which is national, it's direct to consumer, and I'm currently the chief clinical officer there. So anyone who downloads our app and website can actually get care right now, actually. So that's what I've been doing the last 5 years.
Thank you so much, Davis. Peter, great to finally meet you in person. Would you like to go next?
Yes, it's very nice to see you, and I gather that we have a close friend in common. Steve Chan said to give you his best wishes.
Thank you.
So look, I'm Peter Yellowlees. I'm a psychiatrist at UC Davis. I'm also the chief wellness officer there, so I'm particularly interested in the overlap between technology and provider well-being. I've been involved in this field for more years than I like to think, and I've been seeing patients for over 25 years now on video. And since COVID, I've been seeing 100% of my patients on video. So just as have all of the psychiatrists at UC Davis. So we're very interested in this whole interface of technology and clinical care, and look forward to hearing what people have to say.
Thank you so much, Peter. And Albert.
Good afternoon, everyone. I'm Albert Chan. I'm a practicing family physician and Chief of Digital Patient Experience at Sutter Health. Sutter Health is a integrated delivery network in Northern California with over 14,000 clinicians and 53,000 employees. And we're proud to be headquartered in Sacramento. And I thank you very much for the invitation to this panel. One of the benefits and joys that I've had at Sutter Health is to lead our telehealth implementation, where in a matter of 4 weeks in response to COVID, we increased our video visit volume from 20 video visits per day to 7,000 video visits per day, helping over 4,700 clinicians on board and get ready for this. So I'm really honored to be a member of this panel with these great leaders. Thank you.
Thank you so much, everyone. I'm excited to be part of this as well, too. The amount of experience and expertise here is just exciting. So before we jump into it, a few things to go over. We are going to try to hold questions toward the end. We have basically 150 to 235 for panels and 235 to 255 for Q&A. However, if we can get through some of the questions we have for the panels earlier, I am all for, just like 7-minute panelists, to have questions earlier on in there. So please divert your questions to the Q&A window, because that's where we'll be reading them from. But before we do that, we would love to have some participation from the audience just to kick things off. And you can actually type your responses here in the chat, because it'll probably be easier to follow. We as a panel thought it'd be really fun to start this off with asking you, the audience, to please, in the next minute here, type in a 1 to 3 word response of, and here's the question: how does COVID redefine what you, that is you, the audience, as individuals, expect from healthcare system going forward from this point onward? Okay? So the question is, how does COVID redefine what you expect from healthcare system going forward from this point onward? And please, 1 to 3 words only. We're gonna take 1 minute to see all the different responses coming in. That's gonna help define some of the tones and directions we're going here. So please type in those. We got virtual and faster, speedy response from doctors, more digital transformation of healthcare, that's 5 words, but it's cool. Equality, considerable patient innovation, embrace of technology, contactless, consistent, caring, cool. Agile methodology, vast transitions to remote, less in-person visits, interesting. More responsive and listening. Okay, I see a trend here. Prevention, building immunity, continue to innovate care models with a blend of tech and, well, you're in the right panel. Digital accessibility, medical reports. Holistic patient care. Ooh, utilizing food as medicine. Neat. Telemeds and better integration of systems and tools. Cool. Accessibility for those who don't have it. Okay. Prevention, health, equality, data use. Excellent. Anyone else? Any more else? I love this. This is great. This is this definitely gives us a really good direction to go with. Okay, cool. If we have time, we can maybe do a word cloud, but if not, we definitely already have a lot of these to go with. Oh, more home visits. Okay, there's I don't know about you panelists, but there's a very strong trend here already. Awesome. Okay, so I think from there, let's go off to some of these questions that we have for the panelists. And like I said, depending on how fast we get through these questions for the panelists, we can jump right into Q&A with the audience. And please, I ask the audience to send your questions to the Q&A function so that we have that all in one list. So we don't have to go jumping back and forth between the chat and the Q&A. And then when we jump into Q&A segment, we can go straight to that list there. Okay, here's the first question. I'm just going to ask this to the panelists, and whoever wants to answer can answer instead of me calling out anyone here. But here's one of the first questions. So we want to talk about policy a little bit. And we want to talk about how policy has impacted startups' ability either to succeed or to fail in this particular, especially now in this particular era that we're in. Are there any rules that are specifically that need to be addressed and to change policy going forward now, both on a federal and a state level in terms of innovation healthcare? So anyone like to take that question right now to the panel?
I can start with that. You know, as I think others have discussed, the pandemic has accelerated digital health transformation that was already underway, and it's impacted policy as much as it's impacted anything else. In March, Congress gave the Secretary of Health and Human Services the ability to override change requirements for telehealth that actually had been hindering its broad distribution. So I want to say three things about policy. The first thing about policy that's important is that policy defines what you can do and what you must do. And if you're a startup, you need to understand how policy impacts you, but perhaps more importantly, you need to understand how policy impacts your customers. And if your customers are health systems or clinical providers, there is a whole lot of regulation and law that impacts them. And if you don't understand that, it's going to limit your ability to connect to your customers. The second point I think would be based on some of the things that Dr. Arif was talking about. We saw a dramatic uptick in telehealth, primarily because restrictions on telehealth were lifted. And those restrictions were things like where the patient is, or where the provider is, or what kind of technology is being used. And by waiving those restrictions, it allowed for the health systems to implement telehealth in a much broader way than it has been before, where it's been more limited to patients who fit the constraints of whatever the rules are. And so the one other thing I would say in terms of that is if you have plans as a startup to sell into the market based on what the rules are today, you need to be aware of the fact that the rules are temporary. You need to know that there is a bill in Congress right now to try and make the rules permanent. You need to understand what that is, and you need to consider thinking about, do you want to lend your voice to trying to get that bill in Congress passed so that some of these changes become permanent? And then I wanted to touch briefly on remote patient monitoring. I don't know how much it's changed specifically during COVID, but it is important to know from a policy perspective that if you go back 5 years, there were no payment codes for remote patient monitoring. And now there are about 5. But again, if your business model depends on those remote patient monitoring codes, there is a discussion in Medicare on the payment proposal for providers for next year, where they had been talking about removing the one that pays for the devices that are involved in remote patient monitoring. And that's important because you have to know whether the doctor or the patient are going to pay for those devices if the payer stops paying for them. And so if you weren't paying attention and you didn't notice that that thing went away, it could completely destroy your business model. So the point I'm trying to make here is that even as a startup, you have to understand policy and how it impacts you, how it impacts your business model, and how it impacts your customers. And then one last thing on that, I guess, is because states run Medicaid, the federal rules can be adapted or waived in states under certain circumstances. So if you're going to operate in all 50 states, and again, if your business model depends on payment by a Medicaid plan, you're going to need to understand what the rules are in all 50 states, and they aren't necessarily going to be the same because they're not consistent.
Got it. Thank you. That's great information. And what I got away from that was, if you're going to play this game in healthcare, you need to know the rules as detailed as possible and understand that those may not apply tomorrow. Great. Any other panelists like to jam in on that before we move on to another question? No? All right. Fantastic. Great. Thank you, Larry. That was really insightful and also very, very valuable. Another question we had popped up for our panelists was the speed of innovation. Exactly how's it going? Is it going too fast or faster than we think, or is it actually going slower than we want? Are we happy with where it is right now, or are we actually wanting more from it? So I'm going to throw this again out to the panelists who want to answer or take that question. Please take it on.
I'll take that one if that's okay.
Absolutely.
So I think the speed of innovation in healthcare is usually, we'd like it to be faster, but in fact, it's a lot slower. As a digital startup, when we started in 2015, we had to buy a fax machine, it turns out, because it turns out if you want to report STD screening positive results on chlamydia, the only standard in the United States, even in 2020, is a fax machine. So despite being digital startup, we have no need for paper. We're fully direct to consumer. We have no bricks and mortar. All visits are virtual. We had to buy a fax machine. That being said, we've been in this space 5 years. When we first started, we had birth control in California. Now we're national in all 50 states, and we have at least 15 service lines. And my suspicion is most people on this call have never heard of us because we're so tiny. That being said, one day you're going to discover, of course, we do everything online through the app and website first. And if I have to see someone in person, I will do that. When did that flip happen? It's going to be a little bit faster than you think, but pretty slow right now watching it from above the ocean.
Fantastic. Thank you, Davis. Any other panelists want to comment on the speed or the rate that we're actually evolving right now?
I'm sorry, Peter, did you want to say something?
Yeah, I mean, I think it's been very interesting because, look, certainly if you look at the sort of the telemedicine world, which several people have mentioned, it's been really slow over the last sort of 30, 40 years. And every year we've been saying, hey, it's going to change. We're going to get to a tipping point. And there's suddenly going to be a lot of alterations. The only problem is we didn't put in place a pandemic. And obviously, you know, tragically, with the pandemic, I mean, the speed of innovation in terms of telemedicine has been just extraordinary over the last 6 months. I mean, I think between April and May, there was an 8,000% increase in the number of insurance payments made for telemedicine compared with the previous year. That's gone down a bit, and it's now only 5,000%. You know, it's been a dramatic change and a dramatic tipping point. And I think the interesting thing, just to go back to also the first question on policy, is that the federal government knew exactly what the barriers were, okay? People like me have been telling them this for 20 years, what they had to do to sort of open up the market. And so when the pandemic came, they actually knew exactly what to do, and, you know, give them credit for doing that. They actually relaxed, you know, regulations on reimbursement, licensing, prescribing, and security. And those have really opened up the market and allowed the innovation to occur that has happened in the last 6 months. What I think is going to be interesting as we go forward is that a lot of patients are also now being seen on the phone. Increasingly, there are texting sort of approaches, email approaches, other online approaches. In the past, from a policy perspective, there's been a sort of payment stop from video to everything else. And there's been payments for video, but not a lot of the other areas. And clearly that has to change. And we've got to start now reimbursing for a wide range of online approaches. And I think once that happens, then we'll get much more dramatic innovation in those other areas, not just in the sort of the video and currently telephony areas.
Larry?
Yeah, I wanted to make 3 observations about innovation and the pace of change. There are 3 primary, what's the word I want? Something that, 3 primary breaks on innovation in healthcare. The first one is policy, because again, as I said before, it defines what you can and must do. And if the innovation you want to do is counter to the policy, you just can't do it. The second thing is legal. The healthcare industry is very, let's just say, for lack of a better term, there's a lot of lawsuits in healthcare. And so healthcare providers tend to be more cautious than in other industries. So they're not going to be first adopters for the most part, because they're concerned, well, what are the legal consequences if I adopt this technology? And then the third break is on payment. If the innovation is great, but it doesn't add to the bottom line, or worse, if it takes away from the bottom line, if it's a cost and not a benefit, if it's not reimbursed by a health plan, that will slow down the pace of adoption. So those three things are really important in terms of the pace of change.
Fantastic. Yeah, great insights. And that's actually a great break into our next question here that we had. And that was, how, if you're innovating in technology, either devices or software, what is a great way to make sure that what you're doing is actually what a provider actually wants or needs to actually become an early adopter in the first place? How do we really try to improve this technology development between providers and developers? And would anyone like to take that question?
I'll take that one.
Yes,
From the perspective of educating the new generation of providers, I think it will help somebody to know why somebody has that calling and why they choose to go in a healthcare profession. Mainly because they want to help people. They want to have that connection to the patient. And whatever the device or the technology or the platform that it's designed to enhance that, it has to give that connection to the patient. Those are going to be the ones that healthcare providers are going to want to include in their portfolio and learn about it. The other aspect is, will this technology give me as a healthcare provider the data that I need to make a clinical decision for the better health of my patient? And sometimes we can be inundated with the amounts of data that a device can produce. That is very hard for somebody who's not technical. I'm not an engineer, I'm a healthcare professional. Inundated by, and you can do this and that and have this bells and whistles, that breaks actually the adoption. So I think keeping in mind why somebody is there to help, to deliver healthcare, to care for patient, and then how can we help that process by maybe including the healthcare providers into the design from the beginning, because they know what the patient needs. Their healthcare providers are probably the best people to identify the gaps, the needs. So including them from the beginning, it's one good strategy. They will give you input, they will identify the needs, and there's a better chance that they will use that device or platform or technology if they have been co-creators of that. So that is something that works when you bring the person that connects to the ultimate consumer, the patient, the person that is one consumer themselves because they have to use the technology, and then the innovator minds that actually can build it. And having somebody that can help them translate, because all of those three groups have their own terminology and ability to communicate. And that is something that sometimes breaks in between. So I think partnering with healthcare providers, partnering with education professionals to ensure that translation from one group to another happens. Those are my thoughts.
Great. Thank you so much, Nicoletta. Any other panelists like to jump in there?
Yes, Francis. So I'd like to take that one as well. So the biggest mistakes often people make, I think, in startups and starting new businesses and change is you have to find who's the customer and what's their pain point. And so Larry absolutely brought up the correct things about healthcare, the three breaks, kind of like regulatory, legal, and payment. Lemonade by Design has chosen not to play in the payment space. We don't deal with insurers. That's a strategic choice. We are fully compliant with all the medical regulatory things. So the fact that the things were dropped this year actually did not help us. It helped our competitors, but that's all right. When things flip, we'll be good to go because we've always been regulatory compliant. And from a legal and regulatory perspective is if you're going to do this, you have to understand being in a heavily regulatory space is both a good thing and a bad thing. It's a good thing is once you figure it out, you've got a bit of a moat. It takes energy to actually get it compliant and do all the things. But the downside, it takes energy and things to get it done. So it's a trade-off. But the reason it's really important is, from my perspective, what do patients want? Because a lot of it's often around what do clinicians want, which I know what clinicians want. I've been a doctor at Kaiser, and then what do patients want? And it turns out, I think we've been seeing this in pandemic. They want hassle-free, worry-free care when they want it, where they want it, that's safe and appropriate, right? And then the challenge for the healthcare system has been, well, how do we do that? Because as Larry highlighted really well, it's entangled all these three major pillars. And as Dr. Yellowlees also said too, telehealth has been around for like 30 years. I mean, doctors like Marcus Welby, I'm sure, picked up the phone and said, how can I help you? That's not a new thing. And yet it took a pandemic to unleash that. So I think for innovators in this space, make sure you, to Nicoletta's point, you have to have the right people in the room. You better have clinicians and other people who know domain expertise. Because the biggest mistake I see people in healthcare is like, oh, well, I had a bad experience, therefore somehow I have a solution, which may not be a real pain point. The thing that will actually accelerate, I think, the innovation is the fact that healthcare is unaffordable. The fact that patients have high deductibles. The fact that people don't have access to care when they need it, right? And that's what's going to push innovation, because on the fringe, you're going to see people looking for alternative solutions. The same way you do when we have auto insurance. High deductibles, what do? Whether live with the ding in our car, we go to Jiffy Lube, right? We can't do it through our body. You can't just let a ding in your body kind of just go on forever. But you don't know, people are already making those choices, whether we believe it or not. And that's where we're seeing that gap. And I think the innovation is going to come when people say, look, what are the pain points? And more importantly, who's your customer? And then given all the regulatory aspects, where do you want to play and where do you want to win? Having said all that, it's not easy.
Well, thank you there. That's great. Anyone else? Oh, Larry, please.
Yeah, I want to emphasize two things that Davis said. The first thing that's most important is know your customer. If you don't know who you're selling to, if you don't understand what their problem is, don't even bother having a business. I think the second part that he said that's really important is you need to understand what their top three problems are. Because if your problem is not their top three, even if it's a real problem, you will not get any attention. And then I wanted to add a couple of things. You need to understand, how does policy or regulation impact the customer's use of my product? Is it going to create a new problem for them, or is it going to make their life easier? Because it won't be immediately obvious which direction it goes until you work with your customer to figure that out. And then lastly, you need to understand clinical workflow if you have anything to do with the provider. There are a lot of, quote, cool technologies that are useless because they do not take into account how providers practice their craft.
Yeah, Larry, let me just emphasize this point. If I had a nickel for every person that told me, if you can just change your clinical workflow to meet my technology solution, my God, I'd be a very rich man. Let me just say that.
Yes, preach it, Albert. Absolutely. Okay, let's move on to the next question. And actually, this one I was interested in. This is going to go next follow-up in there, especially for people who are wanting to start their own technology startups and solutions. There was a concept that was brought up to us. I learned about it very recently, just a day ago, called SPACs, and which is special purpose acquisition companies. That could be a cool strategy for startups, especially when you're looking at solutions toward like healthcare equity or provider burnout, or all these types of niches that can be met. Would one of the panelists like to talk a little bit about that strategy going into the healthcare technology space?
I think it really raises thank you, Francis. I'll try to take this one a little bit. I think this is really an opportunity to think creatively about solutions to help support startups and other solutions. This is one of many avenues, but what it really highlights for me is the importance of considering the unintended assumptions and unintended consequences of any solutions that we develop. So I'll make a couple key points. One is, fundamentally, this is not about technology, actually. I know this is a technology panel and everyone is very expert in delivering technology, but this is about access to care, because there is no quality of care without access to care. And we as medical professionals, clinical professionals, have this tremendous responsibility and opportunity to be a part of our patients' lives in the most intimate ways. So one of the challenges I would ask is, are we making virtual care available to all of our citizens, all our patients, in an equitable way? You know, some of my colleagues at UCSF published some work in the New England Journal of Medicine Catalyst that suggests that there's differential uptake and there's essentially health disparities depending on your age, your race, your whether you're rural or urban, things of those natures. And for example, at Sutter Health, we've been looking at our own data and realizing we needed to add more language translation services. We needed to add, in fact, important educational materials in languages such as Chinese or Cyrillic or other things, because we needed to meet our patients where they are. Second thing is, I want to really piggyback on what Nicoletta said about education. It strikes me that we fundamentally had this rapid ramping up of telehealth, but were we digitally literate to embrace this? To borrow Davis's term, this is very much like a fax machine. Actually, I think we're still in the fax machine era of telehealth. I'll tell you, I'm inundated with lots of data, but I need more data. Like I need another new workflow. What I really need is insights. And our future leaders, our future clinicians, equipped with the data analytic skills necessary to be able to take advantage of these insights and to be able to process this. And so I do think there's an opportunity to really educate our clinicians differently. Finally, back to the clinicians, what has not changed is the work of delivering care. So we are fundamentally delivering care in new ways, but our in-baskets are still full, if not fuller than they used to be. Research at Sutter Health suggests that for every 3 hours spent with patients, we spend an additional 3.08 hours doing administrative work. That's unsustainable not only as a company, but as an industry and as a society. Because if many of our physicians who have spent at least 11 plus years training to be clinicians, ultimately at the end of that decide they don't want to be clinicians anymore, that is a social challenge. And my final pitch for our startup community is, we can't do this alone. We just absolutely can't do this alone. So we need robust partnerships to make this happen. I'm fortunate at Sutter to have some great partners in innovation and legal and health plans and other things to really try to reimagine how we do these things. But we clearly needed partnerships with our community and other innovators. So.
Thank you so much, Albert. Anyone else? Oh, Davis?
Yeah, I want to add to what Albert said. One of the things I tell my team is that we're fortunate at Limited Health. We have a CTO, Chief Technology Officer, and we own the whole stack, right? And it's a technology team that makes the magic happen, right? Because as Albert said, it's high tech and high touch. We often get confused, oh, technology is going to make it better. Well, if it interferes with the doctor-patient relationship, that's actually a negative, right? And so the beauty of our service, for example, we beam into people's homes, right? Patient with depression, anxiety. Like sometimes I didn't realize this as a primary care doctor at Kaiser when we have same day access, but they were telling me, these are patients I've met at Lemonade. Sometimes depression, anxiety is so disabling, so much inertia. Just waiting in my waiting room at Kaiser, you know, any office, you know, Sutter, Mercy, UC Davis, that would be too much. The fact we use technology, high tech, and beam into someone's house, right? Do an assessment, mail the medicines directly to them, because we actually have also an integrated pharmacy, and then follow up with them with high tech, high touch. That technology actually enables the doctor-patient relationship and actually causes more therapeutic to happen 2,500 miles away, which we do. And so to Albert's point, making sure that the technology is not just a cool thing, oh, it'd be nice. It's like, how does it help me take care of the patient? How does it help me with the relationship continuity? And how do I get high tech, high touch? We're used to healthcare being very episodic, and really it's so about continuous. The challenge is the gap between the status quo before COVID and the future state. We're in the transition phase because to Albert's point, we don't want every single EKG reading off their live cord because that would just drown us. At the same time, there's a mismatch because we know the tools have to exist, but who's talking to the receivers of the data? Who's making sure the customers, the patients are appropriately using their data, right? Because we know innovation is going to happen. If anything, I'd say is innovation for the future leaders, to Albert's point, are going to have to keep going to panels like this to really get their ear in both ends. Because if they expect their aside from a few esteemed colleagues here, their academic medical centers to actually give them the future, odds are probably not the general doctor in the office and things like that, just because they're busy with lots of things. And trying to envision the future can be really hard if you're trained, as in many ways hasn't changed a lot since I graduated in '97. So what I only say is the technology should really be high tech, high touch. Really should enable the doctor-patient relationship in a way that, in many ways, technology actually made us more separate and more isolated.
Thank you, Davis. Peter.
Yes, if I can just jump in. I mean, I think one of the things we have to start doing is evaluating all technologies on their impact on providers, which really hasn't happened in the past. You know, we've got to start taking that seriously. And so I think there's a huge area for startups to work on there, just trying to look at what actually is the impact. I mean, just like Sutter, we know that literally every single person who comes into our primary care system, the average physician who sees them spends another 10 minutes after hours writing notes and doing things on that particular patient on average. So if you're a primary care physician and you're seeing 20 patients a day, you've got 200 minutes to do after hours from that one day's work. And that's our average. If you actually add up the number of consults we do in our primary care network and the amount of time our physicians spend in our EMR after hours, it's quite extraordinary. So, you know, that's clearly unacceptable. And we can't continue on with that. And so we do absolutely have to start now thinking about, you know, the well-being of providers. Now, my personal view is that actually, if we use technology intelligently, if we move more to hybrid relationships between doctors and patients, whereby the relationship is online and in person, and you use multiple different approaches to the online relationship with lots of different technologies, depending on the situation, that actually there are a lot of advantages for the provider. I mean, the big advantages that providers have seen during COVID have been essentially scheduling and geographic flexibility. People have been able to work from home, and they've been able to work at hours that are more convenient to them in many instances. And I think we're going to gradually move away from a traditional sort of, you know, 8 to 6 employment that we have in healthcare, and we're increasingly going to be working from homes or other community settings, and at hours that are more convenient for both ourselves and for our patients. Because in reality, most patients still have to take time off work to come and see us, whereas it would be much more convenient if they could see us in the evening. So I think there's going to be big changes there in the future, but we really do have to focus on this provider well-being issue. And it's good to hear people talking about that, because I think for startups, that's an area of tremendous opportunity.
Excellent, thank you. And I'll jump into this last question before we open up for Q&A from the audience, because there's...
Let me add one more thing real quick.
Oh, yes, please, sorry. Yeah, sorry.
So one of the things that we also have to keep in mind is that there are some things that technology cannot fix that only policy can fix, right? So there are some things that are causes of clinician burnout, but the causes are because they're trying to meet all of the ridiculous regulations that actually don't help patient care. And so I completely agree with what everybody said up until this point, but I would just caution that sometimes there isn't a technological fix. Sometimes we just have to fix the law.
Yep, absolutely. I totally agree with that too. Not everything is turnkey solution necessarily. Now, Peter, you brought up that whole term of hybrid care. I'd love to dive in a little bit what that actually means. And also, and anyone in the panel here, what are some specialties that you think are especially poised, ready to take advantage of this hybridization care going forward from COVID onward?
So I'll kick off simply because you were kind enough to use my name, and I've written a lot about this if people want to sort of Google it. I mean, I've been personally working in a hybrid way with patients that I see for several years now. A lot of my patients are physicians. They, quite honestly, would rather not come and see me in person and don't want to necessarily come to my waiting room. And so I've, for several years now, offered people the option of seeing me either in person or on video. And, you know, everybody has my email address. They know that I don't like using the phone. And I work out, you know, relationships on those bases. And I think that is so much more convenient for patients who can make the choice depending on what their needs are at the time, how they want to see you. And you can clearly also make the choice as to how you want to see them. So I think there are almost every discipline is open to hybrid approaches. I can't think of any where this wouldn't work. It's particularly good, obviously, for the consulting disciplines. But there's really no reason why we shouldn't be doing hybrid care right across the whole spectrum. And so some disciplines like psychiatry, pediatrics, geriatrics, those sorts of areas are going to be able to do a lot more online and maybe less in person. Others, maybe surgery and some of surgical specialties in particular are going to do more in person. But I think we have to start moving in that direction. And certainly, I mean, the aim at UC Davis, for instance, is to long-term have about at least 20% of all of our consults done through our outpatient clinics, both specialty and primary care, done on video. And obviously we already have huge numbers of patients accessing us directly using secure messaging through the EMR. So I think these hybrid approaches are really important, but again, we've got to look at what's the impact on the docs and on the nurses who are providing that care, because that still takes time. And so we have to be very careful about that and make sure that we're not burning everybody out and that we actually evaluate the various different approaches.
Fantastic, Peter. Anyone else like to jump in on that? No? Okay, if that's the case, then we're going to jump right into this whole slew of Q&A questions that I see on my screen right now, which is my favorite part. Now, I'm going to pick and choose which ones I think are constant. This one is kind of near and dear to my heart because I always have a soft spot in my heart for students. And this is obviously open up to the entire panel here. Jada pretty much asked, what advice would you give or would you have for students who are going into healthcare after this pandemic, especially those who are trying to work for hospitals or are trying to do their own practice? Words of wisdom, please.
I'll start on that. I think the most important question that you want to answer is why, for yourself. Why do you want to go in healthcare, and is that truly your purpose? Because that inner motivation will carry you through the hardships and challenges of going through the medical school or through the health profession that you choose and through the rest of your career, as you have heard. Those are not easy jobs. Those are careers, those are callings. And that why is the first thing that you want to consider. And then if you're thinking about the technology and how that impacts your future career, I think looking at the education system or the schools that will have that on their portfolio, that is an important piece to look at. Are they bringing in innovators? No school will be able to teach you of every single platform or every single device or opportunity telehealth that exists. But are they teaching you how to evaluate them and then quickly adopt those that enables you to make a clinical decision that is for the better of your patient? If you get that process thinking critically through that, then I think that is a stand apart professional program or medical school or whatever profession you choose to pursue. They're definitely great callings. You have here a mix of panelists that have that medical background and technology, which is something that you see that it can happen. So I would choose why. I would answer why and then look for an education system, an education university, higher ed, that brings that into your medical education or whatever profession you choose.
Thank you, Nicoletta. Anyone else? Larry.
Yeah, I would just add, if you find people and organizations that share your values and you do the things you enjoy, your path will find you.
Very nice. Thank you.
I think the
Peter?
other thing that's interesting about COVID, to bring it back to the sort of present day a little bit, is that COVID has obviously had a huge impact on the education system and on how people are being educated. And we're really having to learn that from a remarkably slow start. I mean, education, quite honestly, online education is a little bit like telemedicine. It's been around forever, but it really hasn't done very well, except in some schools, you know, where it's become a business model and not necessarily of terribly high quality. And so now everybody's trying to learn how to do sort of either online or hybrid education, literally from, you know, as you know, from K onwards. And I think, you know, as someone who's teaching medical students in this environment, it's going to be, in the end, quite a positive thing. I mean, both medical students and residents, for instance, are all being interviewed for medical schools and residency programs online nowadays. And the schools are having to suddenly think about how can we make ourselves look more attractive and how can we do things more interactively? How can we work differently with our students? How can we teach very differently? I mean, one of the things that we're trying to do is to actually look at how do we run our meetings differently. Now, in fact, Francis, you're doing a great job today with Laura by keeping them interactive. I love the way that you brought the audience in straight away and that we're doing the audience questions. I know when I give talks on video nowadays, I typically leave several gaps in the talks to specifically take questions actually as I'm going through the talk. Whereas in the past, I was just used to have questions at the end, as is the tradition. And I think it's clearly much better if we can be interactive and involve the audience. And so when you actually talk to a lot of students, they'll actually say that I mean, I know our residents have actually said that they prefer having the online didactics because they can be a bit more in control of them. If it's really boring, then they can just turn off their video and go and do something else. But if it's really good, then especially if the groups aren't too large like this one isn't, then it gives everybody a chance to actually say what they're thinking. And it's a bit more egalitarian than maybe traditional education settings. So I think we really need to think about the whole education process in just the same way as we're thinking about healthcare provision. And there are just as many opportunities for startups there as well.
I love that, Peter. Absolutely. Albert, please.
So I'd love to give advice to Jada to say, invest in your relationships. I know this is technology talk, but please invest in your relationships. I had the opportunity to speak with Professor Angela Duckworth, who wrote the book called Grit. And she talked about pursuing what you love to do, as Larry said, the passion to pursue what you're passionate about in your career. But I would also say that part of my life has really benefited from great mentors, a very supportive family, and my patients who continue to inspire me each and every day to survive through some of the challenges that we faced, whether they be COVID or anything else for that matter. So please invest in any relationships that you have, because they'll help you be a better leader, a better innovator, and a better person.
Very wise words, Albert. Anyone else want to jump in before we move on to the next question? No? Okay. Here's one I got here that I think this is really interesting, and I'd love to hear the panel's response on this one. So this is from Tony. He asked, in trying to develop this trial with a major provider network, we have started by identifying an internal champion who builds tremendous momentum, only to have legal, regulatory, IT, and other administrators slow down and or completely reject the proposal. Does the panel have any suggestions on how or strategies to avoid or even preempt this in the first place?
Yeah, several. First of all, you can't avoid it. You will always have that risk. Second of all, you need to very carefully understand what the pushback is. It's possible that if the pushback is in such a way that you can't fix it in your product, then you need to find a new product. It's possible that it's something that you can tweak, but again, you have to get as much feedback from the people who are saying no as possible to understand why they're saying no. Sometimes it's something as simple as, we don't have the budget for that, or we have other priorities that we're focused on right now and we can't talk to you, or there are so many things that it could be. You really need to focus on, what are they telling me? Are they telling me I need to do something to change my product or change my approach? Or are they telling me I don't have a product that anyone will use?
Thank you so much. Anyone else like jump in for that?
The only thing I'd say to Larry's point is you have to find out who the decision maker is. Who is the veto power? Because oftentimes someone's very passionate, but they have no power. And so often you get fooled into the most passionate person thinking they have power, when in fact this sounds very much like many large organizations I've worked with before. It's always one person who has veto power. And if you don't understand who the decision maker is, you're just wasting your time. So that's probably the only thing I'd add to not only Larry's about the feedback, product market fit, all that important stuff, but who actually has veto power, who actually has the dollars to spend.
Right. Yeah, what I'm hearing from
One other
this
thing
is-
also,
yeah, please
because I
start,
do want to
Larry.
emphasize that you're right to start with a champion, right? Because if you don't have a champion, you will not even get heard. So you are at least starting with the right first step.
Yeah, what I'm hearing is like the second step, then Larry, is find out who the boss is, right? Yeah, that makes sense, absolutely. Okay, this is a question I think is the next question I'm looking at. This one seems very patient-centric, and should we, I love to hear what the panel says. And essentially this is from Mo. Can a patient actually ask for a copy of all their medical records, all their medical health records from a health provider and save it to another system? Is that possible yet right now, from either legally, policy, or technologically?
So the answer is yes. People, well, I shouldn't say people. There are health systems that have used HIPAA as an excuse for not sharing data for years. But that's not what HIPAA was about. Many people think that the P in HIPAA stands for privacy. It actually stands for portability. The whole idea behind the HIPAA law was to enable data sharing, not to block the sharing of information. And so HIPAA is sort of misused in that way. Now, in fact, I want to say in February of 2017, the Office of Civil Rights, which manages HIPAA violations, actually came out and gave guidance that said, if the patient requests their data in a digital format and you can send it in a digital format, you have to give it to them in a digital format. So in fact, yes, there is plenty of things that will support you from a regulatory and legal standpoint to get your data and pretty much send it wherever you want. The challenge is finding the tools that will enable you to do that.
Fantastic. Thank you so much, Larry. Anyone else want to jump in? Davis?
Yeah. So actually, to answer Rachel's question, there actually is a company that's actually doing that right now. It's actually Apple and their Health Kit. So actually, I already have my Kaiser data on there. And so again, watching innovation is, healthcare took a pandemic, to Dr. Yellowlees' point about going to telemedicine, it's been around for decades. I mean, on the edges right now, Apple's quietly assembling all your records, because we know Microsoft tried this, Microsoft Health Bot. We know Google tried this, Google Health. It didn't work because people don't really want to type their own data in. And it failed because they never asked the customer, the patient, like, what do you want? And Apple goes, what do people want? Because as Steve Jobs once said famously, if Henry Ford had asked what people wanted, they would have said, Henry Ford, I'd like a faster horse, right? The problem to be solved is I want to go from point A to point B. What Apple's doing right now with the Apple Health Kit is saying, look, what patients really want is access to the medical records in one spot, but they don't want to type it in. That's where Google and Microsoft failed previously. So watch this space, because you're going to see the big tech companies, going back to Jada's question about healthcare. Healthcare, as everyone knows on the panel, is 1/5 US GDP. So a big company like Apple, Amazon, if they want to please their shareholders, figure out what their next big thing is to kind of disrupt, it's going to be healthcare.
And if I can just comment on, the open notes process, I mean, this is just about with us. I mean, within the next month or so, we're all going to be in a position where notes have to be available, or the great majority of notes have to be available for patients and have to be able to be delivered digitally, as you correctly say. So I think in principle, that's a great thing. I'm very supportive of it. But there are some potential issues that patients may not understand if they send all of their notes to, for instance, Apple. or whoever, because Apple's not going to be protecting those notes to the same level that our current EMRs are, and people who you don't necessarily want to see your notes are, it's going to be quite possible that might happen.
Thank you, Peter. Anyone else like to jump in? All right, fantastic. So great insights for how the current state we are in EMR ownership. Here's the one that actually would kind of jump right into this one, that question follow-up then. This is from Sandeep. Over the last 4 decades, have the regulations helped patients and physicians, or do you see that the regulations are actually stifling innovation in healthcare and creating even more bottlenecks in delivery of care at all? Anyone in panels?
Yeah, there is no simple answer to that question because all legislation is messy. There are things that have specifically helped patients. There are things that may be neutral to patients but have harmed providers. So I would say we can't answer that question with a single answer. There is legislation on all sides of that you could use to say, there's a benefit. So for example, the recent Cures Act, it required the ability to get your data and share it with any third-party app that you choose. The process for implementing those regulations finished about a month ago. It's supposed to take effect actually next week. However, the powers that be recognize that we're in a pandemic, and so it's likely that that's going to be postponed. But things are coming that will make your data more available to you. On the other hand, there are things that are constraining. A lot of the billing regulations are really challenging. They lead to things like both Peter and Albert were talking about in terms of clinicians having to spend an unreasonable amount of time on documentation. That serves no one except to make it harder to document. It's increasing the risk of clinician burnout. It's leading to people leaving medicine as clinicians and moving into spaces like technology. But I would say that on par, they're probably more negative than positive, but I would say there are legislation and regulatory things on both sides, because when something is passed that becomes negative, there's usually enough groundswell to make some changes to improve it.
Thank you. Anyone else would like to jump in on regulations and innovation? Question? Davis.
Oh, I'd love to take that one. Can I take that one too? So one concept I love is something I learned years ago. Is called TBU. True but useless. I mean, that's nice. Healthcare is regulated, but that's true, but it's useless. So a couple things. Number one is, the automotive industry is very highly regulated in one sense, right? How you build a car. Flying into space, pretty difficult thing. And then we got some guy called Elon Musk who decided, you know what, I'm going to electrify cars. I'm going to go do SpaceX, and realize he's lost capital. But he really asked himself, why is the innovation happening? Because the status quo isn't going to actually disrupt itself by definition. That's just how every sort of thing is, right? All the new innovations. Blockbuster didn't build Netflix. Netflix built itself. Amazon didn't come out because Walmart could have built Amazon if you think about it. They could have gone e-commerce, but it was actually Amazon who came out of that, right? So again, in general speaking, you look at any sort of industry, the current status quo usually doesn't cause the rapid change that happens. That's number one. Number two is that even within regulations, you can build innovation. So a good company, a lot of people probably know, is Omada Health, who actually does digital diabetes care online and all that. And they actually built it out. It's been a few years now. They actually got CMS to actually give them codes to do digital coaching, and they used it based on doctors and health coaches, and they went to the employer groups and got self-insured to pay per member per month. But this is a long road, right? But they had a deliberate strategy. We're going to go business to business. We're going to make sure we follow the regulations, and as we get better, we're going to go to the CMS and other people with proof of concept and get reimbursed. So I actually got the first time I believe CMS actually gave any sort of digital reimbursement codes actually for Omada Health. So regulations are there. It's like gravity. It's true, but useless. I don't like gravity, but I'd like to jump up, 20 stories, but I can't do that. That being said, if things need to happen, how do I do that given the constraints I have? And funny thing, which is actually quite true, the most innovative things usually happen when people have restraints, creative restraints. You see that in artistry, any sort of situation of disasters where people really come up with the newest, greatest ideas in times of constraint, and we're seeing that with the COVID pandemic as well.
Fantastic. Thank you so much, Davis.
I want to push back on Davis just one tiny bit. I actually like gravity. I'm a big fan of, I don't want to float out into space, and I like having an atmosphere. So for me, it's all about balance. There needs to be some push and pull.
Fantastic. Thank you. Anyone else would like to jump in on any topics of policy, innovation, or gravity, for that matter? Okay. All right. Here, well, I'm just going to do a follow-up question here I saw from, and I'd love to hear the panelists' view on this. To Dr. Liu's point, and then any of the panelists obviously would jump in, is why did the big companies such as Google and Microsoft, why did they fail to solve the electronic medical record challenge in the first place?
I'll take that one then, since I brought it up. It's out to Albert's point, and it's to Nicoletta's point. People in healthcare, people in technology industry goes, oh, healthcare is backwards. Oh, don't need to use fax machines. I mean, how hard could it be? You just need new workflows. And so they had this naivete about what needs to be happening because they're not domain experts, And what they failed to understand is where's the pain point. So the best collaboration with technology companies and healthcare are when they literally have their software engineers following the doctors around, following all the physicians around their workflow and really taking notes and really understanding the problem to be solved. So Google and Microsoft, I'm sure, will come back later, but they just thought, oh, just put a digital thing, people type it in. Nobody wants to type in their medical records. Even doctors who want to keep their records aren't typing their medical records. So that's really why they failed. They equated, we've done things well here, therefore it's transportable, when the answer is actually not.
So if I can just jump in and just to support what Davis is saying, I mean, I was actually the chief medical officer for a New Zealand company in about 1998 called Dr. Global that eventually went bust. And Dr. Global had a very simple view. We were going to put everybody's medical records online. We were going to have patients flying around the world, seeing doctors in all sorts of different countries. They'd carry a sort of a little card which had their password on them, essentially, and their access code, so that if they were brought into an emergency room unconscious, everybody could bring up their emergency records from wherever they were. And we were going to work with all of the sort of retrieval systems around the world, and essentially get this online medical record going. And I discovered that when I put my own record in there and I tried to keep it up, but even I couldn't do that, as Davis said. I mean, it was just so boring and repetitive, and it seemed unnecessary. And so we very rapidly changed to a different business model. But I mean, I think that is the issue. I mean, it's how do you get the data into one place really easily? And that's clearly what's possible now, and especially with the 20th Century Cures Act and Open Notes coming. And it's going to be possible to get that data in easily without anybody having any trouble. And so that will be a game changer. There's no question about that. And I think the companies that have got involved at the back end of that are probably going to do very well.
Thank you, Peter. I love that name,
Dr. Global. Yeah, that's exactly what we wanted to be.
I'll add a couple of things very quickly. First of all, I agree with everything that both Peter and Davis said. I think the short answer is that the companies were early, and I think that the primary obstacle to them being successful was policy. The regulatory environment both made it harder and did not make it easily possible for them to get the data to make it easy for people to use the product. And again, as Davis said, I think with Apple being in it, I suspect Microsoft and Google will probably come back once everything gets figured out.
I agree with all my colleagues. I'll say one other thing though. What if healthcare was as addictive and simple to use like TikTok? But if you think about TikTok, it's really easy to get content. It's really easy to riff off other people's content. You can spend an hour on it and not even know it. It's crazy. Healthcare is not that simple today, and it frankly should be. So I think all of our app developers need to push ourselves to think like, not saying we should all do TikTok videos. That's not what I'm saying, but it should be that easy.
Thank you. We have about 3 minutes. Would any
I was just
panelists
going to
like
comment that maybe we should be doing TikTok videos if we can get decent voice and language recognition systems going.
That's true. It's true. I mean, let me make one follow comment on TikTok. Here's an example of solving the last mile. So if you look at other systems that try to create content, one of the challenges is you actually didn't have digital rights to music and so forth. So if you uploaded this thing without the digital rights, it would actually get censored because you didn't pay for the royalty for the music. TikTok solved the last mile by actually acquiring rights to the music so that their users today can just simply pick whatever song they want and it works. So
yeah.
all these solutions lack that last mile solution.
Yep. Reducing the friction of the turnkey solution.
Right.
We have about 1 minute left. So I think with that, I'm just going to thank everybody here for such an amazing, fun, and engaging panel. Thank you for taking all the questions that we could get to from the audience. And it's been such a privilege to be part of this. So I'm going to hand it over here to Jeff.